Hello, good afternoon. I'd like to thank Dr. Balamurgan sir for giving this opportunity to talk on intermediate uveitis, the pitfalls to avoid in long-term management. So just a brief introduction. Intermediate uveitis is an inflammation where vitreous is the main site of inflammation, and there's usually an absence of choroiditis or retinitis. Pars planitis and posterior cyclitis and hyalitis are also termed as intermediate uveitis. So intermediate uveitis is less common than anterior and posterior uveitis. It is more common during the second and fourth decades, and pars planitis tends to be more common in the pediatric age group. Many studies show that there's a male predominance of intermediate uveitis in the pediatric population and a female predominance in the adult population. So etiologies, the most common is idiopathic, but in adults, we see masquerades and infectious causes, and in children, it tends to be pars planitis, TINO, or JIA. So patients usually present with blurred vision and floaters. These symptoms are usually mild. The visual loss may be more severe if the complication of intermediate uveitis occurs, that is cystoid macular edema. Anterior chamber is usually quiet, and there may be snowballs and snowbanking present in intermediate uveitis. So investigation, so first we need to have a good history before we investigate any cause of uveitis. So the most common cause of intermediate uveitis is idiopathic, but before diagnosing the disease as idiopathic, we have to rule in or rule out the other diagnosis. So for sarcoidosis, we can do ACE or chest X-ray. For tuberculosis, we have to do the MAN2 test and imaging. For syphilis, VDRL and TPHA. For intraocular lymphoma, we can do tests like simple tests like CBC and peripheral smear. And if we suspect CNS involvement, MRI brain. And for SLE, ANA, and dsDNA with Smith antigen, to know it is important to check the urea and creatinine. And for multiple sclerosis, to do an MRI brain. For monitoring the disease activity, we can do an FFA for retinal vasculitis and OCT to monitor cystoid macular edema. Treatment, you must always follow a stepwise approach when treating. So first we start with corticosteroids, followed by immunosuppressants. And if those are not working, we can start neobiologicals. These is for non-infectious. If the etiology is infectious, we treat the infectious cause. And if the treatment is not working and you want to investigate, you can do a media clearing pars plana vitrectomy. And when you do a vitrectomy, always send the sample for investigations. Like if you suspect TB, do a PCR TB. If you're suspecting a viral cause, do a PCR to rule out the viral etiology. So now we'll just look at a few cases. So this was a 45-year-old female farmer who presented with redness and pain since 3 days. She does give history of contact with cattle and fever 4 months ago. When she presented to her, there was decreased vision in the left eye. She had presented with non-granulomatous keratic precipitates, cells and flare with dense vitreous membranes, and which was also shown on the B scan. So such patients with fever of history with dense vitritis, you would think that maybe she's having endophthalmitis. But in fact, her diagnosis was leptospirosis, and she improved with just a treatment of doxycycline and topical steroids. So what I wanted to say, point out in this case was that vitreous inflammation can occur in 55.4% of patients with leptospirosis. So when leptospiral uveitis is severe, it can look like endophthalmitis, but usually with a good history that a patient is a farmer of low socioeconomic status can give a clue to leptospirosis. Also, when we see a good fundal glow, we should think of an alternate diagnosis to endophthalmitis. Next case was of a 28-year-old female who presented with decreased vision since 1 month. She had non-granulomatous keratic precipitates. There was only mild vitritis in the left eye. So routine investigations were normal. We started topical and oral steroids, but inflammation kept recurring and patient was also symptomatic. So we decided to do a media clearing vitrectomy as well. We did send the sample for PCR analysis, which was also negative. Post-operatively, her vision was 6/9. However, what we missed was she actually had stellate KPs in her in the endothelium. So we should always study each KP properly. And because my teachers say that every KP tells a story. So always look at the keratic precipitates, identify whether it's granulomatous or non-granulomatous. So in the end, the diagnosis was actually Fuchs heterochromic iridocyclitis, and inflammation was well controlled with only topical steroids. Unfortunately, due to complicated cataract, she had a vision of 6/18. So when we can use oral steroids for the treatment of Fuchs, but we are just hastening the complications of developing glaucoma or cataract. So always try to confirm a diagnosis of Fuchs. So Foster gave this criteria: absence of acute symptoms, presence of small white stellate keratic precipitates, low grade anterior chamber inflammation, diffuse iris stromal atrophy, absence of posterior synecdoche, and presence of few cells in the anterior vitreous. The third case is of a 57-year-old female who presented with right eye decreased vision and floaters since 1 month. She gave occasional knee joint pain and history of skin rash. So as you can see, she had snowballs in her vitreous, and she had granulomatous keratic precipitates on the endothelium on anterior segment examination. So we had diagnosed her as a case of ocular sarcoidosis, and we treated with oral steroids. However, after treating with oral steroids, the vision had decreased in her other eye. When we did FFA, we saw the typical ink blot sign of CSCR in the other eye. So we immediately stopped the oral steroids. Inflammation was well controlled, and now she has both eyes vision of 6/6. So I just want to say that always look at the patient as a whole. And when patients come for review, look if there are any adverse effects of the treatment you are giving. Thank you.